Oh, you got this? Okay. Well, good. Thanks for everyone, and thanks for having me here today. It's a really unusual venue, and actually the first time in my 3 years in this position that I've actually been able to come to a clinical group to talk about really technology issues, which are very different. And if anyone doesn't like what I have to say, I think you can find, Patty Riley's over there, because Patty called me a few months ago and said, would you please talk about, what the payers do with technology? And if anyone knows Patty, you can't say no to her. And I said, I don't know. I have to start this from scratch. She goes, please. So I said, okay. I said, so I'll wing it here. But no, thank you here. And I too, and I'm going to share something with this group because it sort of came out when I was hearing some of the other talks. I too have to leave early, and I have a 4 o'clock flight today because I have to be back in Michigan. And my 4 o'clock flight today gets me back in Michigan like 11 o'clock because of the time change. Because I have a 8 o'clock meeting in the morning. Does anyone know what the Keystone project is? Keystone Center for Patient Safety? You've heard of it? Kevin's heard of it, I'm sure. Keystone Center for Patient Safety is actually sponsored by the Michigan Health and Hospital Association, and that's where some of the things like checklists actually came out many years ago, and a lot of Peter Pronovost's work actually came through there originally. And we've actually shown, and Blue Cross Blue Shield of Michigan actually donates up to about $5 million a year to support Keystone. So because we actually at Blue Cross, really, we're a nonprofit, and I'm going to talk a little bit about the industry throughout the talk. We're a nonprofit that's really committed to the people of Michigan, and we really believe if we can invest in safe care, actually safe care will turn out to be actually greater value care and less expensive care. Good care is, bad care costs money. Good care is what's actually the greatest value. So what am I going to talk about? I'm going to talk about we're going to talk about the initiatives and how Blue Cross Blue Shield is actually a national leader in value-based care. And I don't know if anyone saw an article, I think it was in Becker's or something like that, just last week, that shows most Americans, and I don't like it either. When I first joined the plan, which was it was a 180-degree turn for me to actually join the plan. It was not something that was in my career plan. It came out of nowhere, and it came out of a very visionary CEO who said, I really want somebody in the C-suite who's been a physician and patient advocate and who understands and can be a voice of the clinician in the boardroom. And that's actually how I got to this position. I had never worked in a plan before. He actually thought he wanted a clinician's voice at the table. And that's really how I ended up there. And to this day, that's what I do. I don't sit there and, I told him, I said, if you think you're going to have a guy that's in there slicing dice and, hemoglobin A1Cs and county 22 and figuring out payment plans, that's not me. And he goes, no, that's not what I want. We're going to talk a little bit about the what we call the Blue Cross Blue Shield, and actually we were talking about it, and we're going to talk a little bit of our support of what we call Aspire, and that's one of our 17, what we call up to 19 now, collaborative quality initiatives, and that's actually helps, again, to take better care, and I'm going to talk a little bit about those. I felt really funny, we were talking about it. Is Nirav here? There he is. So I get all the slides ready, and I'm going to talk a little bit about Aspire. Then the other day I found Nirav's going to be here. So he actually runs Aspire. It's like, well, why am I talking about it if he's there? So I'll talk a little bit about what our relationship is with Aspire, and Nirav will probably talk about the rest. And we're going to talk about new technologies. And one of the things that I really want to get down is, if you've seen one payer, you've seen one payer. As a matter of fact, if you look at anything that comes out of us, it will say, Blue Cross Blue Shield of Michigan, always at the tagline at the bottom, an independent licensee of the Blue Cross Blue Shield Association. So if you say, well, if you're doing this at Blue Cross Blue Shield of Michigan, how come my Anthem plan's not doing it? You're all Blue Cross. Blue Cross is actually 43 independent associations under the same, Blue Cross Blue Shield brand and banner. That they're collaborative efforts, but they're independent. And then, anyone here from California? Okay, California is a great example. California is the only state that really has Blue Cross and Blue Shield as two separate companies. Blue Shield of California is a not-for-profit. Blue Cross is Anthem in California. So there's actually a lot of variations, and we're seeing a lot of consolidation amongst the Blues. As a matter of fact, if you're from Louisiana, you know that Blue Cross Blue Shield of Louisiana they're in the process of getting purchased by Anthem. Our company, Blue Cross Blue Shield of Michigan, is in the process of having a strong affiliation with Blue Cross Blue Shield of Vermont. So we're seeing a lot of consolidation. And there's a big difference between the not-for-profits, which we are, and we're actually, our dollars go back into the community, and the for-profits. I'm not, you know who the for-profits are, the Uniteds, the Humanas, and the Blue Crosses, all except for Anthem, pretty much are not-for-profits. So it's a lot to understand in the industry. So if you say, why are you doing this, but my Blue Cross is doing it, so you have, your same company, we're not really the same company. We coordinate, we collaborate, we look for better ways of delivering care, but we're actually totally financially independent organizations. So one of the things that actually I'll talk about is we're an 83-year, company's been in existence for 83 years. We have, and actually that number of 5.3, we actually have just shy of 6 million members. We're the 9th largest insurance plan in the country. We're the 3rd largest Blue Cross plan by membership. That number there is wrong. It's not 32 billion in gross revenue. It's 40 billion in gross revenue now. And if we weren't a nonprofit and we were on Forbes rating, we'd be about number 283. And we have over 10,000 employees. So we're a pretty big company. We're just not a health plan that's in Michigan. And we do that. We pride ourselves by actually wanting to take better care of people, because we've proven over the years, you take better care of people, you actually become a more successful company. So we're going to talk a little bit about value-based care. Again, a term I really don't use. I'd like to actually change the term to maybe quality-based care or quality-focused care. This is an article that I wrote with my DIAD administrative partner that was published both in Cranes and in Modern Healthcare. And it really shows what is the difference in value-based healthcare. And what it is, we're really focusing on taking better care of people, taking the incentives and making them focus on quality. Drive reliable incomes for providers. One of the things that we learned during the pandemic was if you're in a true fee-for-service environment, it was going to be a struggle to get paid. Now, we advanced billions of dollars in payments so that our providers and our hospitals could keep the lights on. But who knows if we can always do that? And it's becoming, we're now in a catch-up phase. We promote population health. All of our initiatives that you see are going to promote taking better care of our population, getting blood pressures under control, getting obesity under control, getting diabetes under control. And we know as a company, and we have actually strong relationships with our physician community, and that's actually my job. And what we want to do is we want to lower physician stress, and we want to lower physician burnout. Is when you talk about utilization management and quote prior auth, we are doing everything we can, and we have some initiatives we're going to be rolling out shortly to even further decrease the number of prior auths so that we, doctors and nurses and their staff can actually spend more time taking care of people and not computers and not being on the phone. We trust the judgment. We want to do more gold carding. I always like to use an example. My wife's a physical medicine and rehab doc. She is in a practice of 16 physicians, 16 private practice physicians. They have three people that do nothing but prior auths all day. And this is the sense what we want to get away from. So what do we want to do in a value-based environment? We want to optimize outcomes. We want to pay for outcomes. We don't want to pay for just, procedures. We want to pay to show that everyone's doing a better job. And we're going to pay more. We may pay more to do for better outcomes. And as we look at environments where we're looking at risk, and we may pay less when outcomes aren't that good. We're totally focused on patient experience, because patient experience and provider experience will deliver better patient care. And that's crucially important to us. It's crucially important because one of the things we talked about is Medicare star ratings. A huge chunk of Medicare star ratings are based on experience. What are the Medicare recipients saying about their plan? If a company loses a star, when Medicare Advantage recipients go onto their website every year to pick their plan, they're looking at the number of stars. And the number of stars is crucial. And actually, Medicare pays the plans that administer Medicare Advantage products based on their number of stars, and there's thresholds. You lose a star, companies like us could lose up to $250, $300 million by just losing half a star. So you want to keep your star numbers up, because the recipients are looking at stars and CMS is looking at the stars. And affordability. At the end of the day, we've got employers out there saying we can't afford these kind of premiums anymore. We can't afford to pay these kind of healthcare costs. So we've got to figure out, we're sort of caught in the middle. We got to figure out how to work with the providers to make it to have greater value, to make it affordable, so that our employers can actually do what they got to do. We have a defined population. We need a whole person approach. We are spending millions of dollars right now investing in behavioral health programs. And why are we doing that? Because we have learned that behavioral health affects physical health. So the pandemic taught us that, and we're totally revamping all of our BH, or or behavioral health programs, psychiatrists. We don't have enough psychiatrists in Michigan. We don't have enough psychologists in Michigan. We don't have enough social workers in Michigan. And we've got to figure out a way to get the community better care. The one beauty that came out of the pandemic, obviously, is greater telemedicine. And that's sort of what's saving the day a little bit for us. As we're developing programs, we're actually being able to take a look at getting people the care they need on a screen, not necessarily having to wait to get into a psychiatrist's office. And we're driving results by focusing on getting patients the right care at the right time. And that's what our focus is as far as prior auth goes. It's not prior auth to check the box to say no. I mean, 99% of our prior auths are actually approved, but we want to make sure the patient's getting the right care at the right time. We want to make sure there's no contraindication. It's actually another part of the safety checklist. So where are we? Where are we now? So where's Blue Cross been? Blue Cross is really, really different. And I apologize because the one thing I've always tell everyone to do is not look at the screen, but for some reason, the way it's split up, I can't really see it right there. In 2005, we launched what's called the Physician Group Incentive Program. And what that is, it was more primary care focused, and it was a holdback. It was a holdback of X number of dollars per doctor in the state of claims that they received. This money, and it was matched by us, went into a big pool, and then at the end of the year, it was sort of divvied out by who had better outcomes. And it was sort of focused on what we have in Michigan is called physician organizations. At the same time, the CQI initiative portfolio was launched to address areas of hospital care. Now, the CQI initiatives pretty much are procedure focused until this year. And we have two new ones. Actually, we've gone from 17 to 19. We cut one back. From 17 to 19, one of them is back pain. I mean, this country spends billions, if not trillions of dollars in back pain issues, and the other is actually diabetes management. So it's our first venture into non-procedural based outcomes. Our physician group incentive program has actually shown we're able to take better care of people. And we take better care of people. There's 4 meetings mandatory that everyone's at Anesthesia program needs to come to, where we talk about outcomes, and we talk about metrics, and we talk about who's taking care of better care of people, where the obesity rates are up, where the diabetes rates are down, and how can we learn from each other. The one thing about the CQIs, and Nirav may talk about later about his, is in the other specialties. It's, competition, your competitive hats are left at the front door. When we get in there, one of our most successful CQIs is actually the urology one. And they all have these very gimmicky names, and I don't know how we found them. If you want an acronym, come to Blue Cross Blue Shield of Michigan. We will get you an acronym before we even decide what it's going to be called. We'll figure out the acronym first. As a matter of fact, we have 2 Aspires. There's a different project called Aspire, and then there's the anesthesia project called Aspire. But we can acronymize anything. But music, which is our urology acronym, all the hats are left at the front door, all the competitive hats, the academicians, the University of Michigan folks, the Henry Ford Health System folks, the private people in northern Michigan and rural Michigan, they all leave us aside, and they all get together 4 times a year. And they take a look at the data, and they say who's doing things better. And we've shown actually incredible outcome changes of care in Michigan by getting the teams together, regardless of their focus, regardless who's paying them. They come together as docs, wanting to do better work for Michigan. Blueprint for portability products, we're getting out there again. That's value-based. That we're getting in there, and actually at some point there was upscale, that if you did a better job, we paid you more. And as we're working into what we call a full risk environment now, we're going to pay you, we're all taking risks, and we're going to pay you more, a lot more, if you take really good care of people. But now we're actually going to take money back if you're not taking that good care of people. Our goal, we'd love it if you took great care of everybody. That would be our ultimate goal. But I don't think we're there quite yet. So as time goes on, as a matter of fact, in Michigan, in January 1st, 2023, 33% of our Medicare Advantage recipients that are part of a Blue Cross product were in some kind of what we call a full risk model. Not partial risk, which is a little bit of upside, but full risk, that if you take great care, you get a lot more. If you take poor care, you get a lot less. So it's a new paradigm, especially for our PCPs. So here is the slide that I'm not going to talk much about because the experts are here about it. I couldn't be more proud of it as an anesthesiologist. I mean, it's actually, I shouldn't even say it, but it's, Rob will tell you it. There's 19 of them. I don't go to all of them, but I try not to miss my own specialties and get together 4 times a year. The team is amazing. The team does great work. The team brings everyone together. I couldn't be more proud of the work that the Aspire team is doing in Michigan. There are, when we talk about one of our great CQIs, Aspire is always one of them that comes up. So give them some credit. Aspire is what we do. Aspire is really a division of MPOG, and I'm sure most of you have heard of MPOG. And what Blue Cross Blue Shield of Michigan does is we actually pay for our Michigan practices to be in Aspire. So almost every Michigan practice, and the ones that aren't in, that's their choice, because we pay for them to be there. It costs us about $100 million a year. $100 million a year to actually fund all these collaborative quality initiatives. And you say, well, why do you do that? You're a health plan. Why are you spending all that money on this? Because we truly believe, and we believe that the $100 million we spend a year has saved us billions of dollars in better care. And that's why we're so proud of the CQIs. There's a great article that was in New England Journal of Medicine Catalyst about 6 months ago, where we actually talked about the work that's being done. It's 25-year anniversary of the CQIs. High quality measures, review best practices, exchange ideas, and talk about what's working well here and what's working well there, and see if we can come together to do, like I said, take better care. What can we say? 16% of Nirav, you probably can talk even a little more about this. 16% improvement in perioperative glucose, all came from Aspire. 4 times as many patients received smoking cessation counseling compared to 2021. And Nirav will probably correct me if these numbers are wrong. And a 25% reduction in the carbon footprint by some of the work that they're doing to reduce gases in the OR. So as technology advances, healthcare, we're taking a look at how can we do better. So we have partnerships. The one thing I will tell you that any health plan is looking at, we are doing anything we can to keep patients out of hospitals. Hospitals are incredibly expensive places. We are actually in a venture of more and more hospital at home projects to see if we can get patients staying at home, stay in their environment, and we will bring hospital care to them. We've got multiple programs, and actually a lot of them are private equity based. Landmark, in-home care. Actually, Landmark's owned by Optum now. That was just sort of flipped about a year ago. In-home assessments, Livongo, which does A1C management. And I can't even tell you, this is just a small partial list of the vendors that we have. And that it's all, we need technology, and we're willing to invest in technology if it actually can keep people at home, in their environments, and out of the expensive hospitals. So how do we determine this? So at Blue Cross Blue Shield, there's really two splits. There's actually commercial, which is those that aren't Medicare or aren't a government-funded program, and that's those that are under 65, or actually those over 65, and then there's those under 65, which we call commercial. I don't sit in the back of the room and say, oh, I like this policy, just, let's pay for this. I don't really deal much with payment policy at all, except for advocating for what's good care. But what we do is we have what we call the JUMP committee, and that's a Joint Uniform Medical Policy Committee. It's not made up of a bunch of insurance executives. It's actually made up by clinicians. It's made up of really a mixture of academic clinicians. There's an incredible number of clinicians from Ann Arbor on the committee. It's made up of a collection of private physicians who are actually in the fields, actually, taking care of patients, taking academicians who are taking care of patients, academicians who are also researchers, and they all get together to find out what's the best way, what should we be paying for? It's physician-led, it's multidisciplinary. It actually takes a look at clinical evidence, and sometimes it looks at clinical evidence and actually makes a decision based on that. And then we'll create a medical policy that informs the benefit and reimbursement decisions that we make every day. And that's really, really the core of it. It's independent. They're at an arm's length. I don't appoint people to them. We get people who are actively engaged and wanting to take great care of people. And that's what the JUMP committee is all about. And the JUMP committee makes it it's evidence-based, and they will actually make the decisions on what they think we should be paying for. One of the greatest misconceptions of healthcare, the JUMP committee can make a decision. One of the greatest misconceptions of healthcare is there's always this, everyone thinks that, we get a call in October after open enrollment to, hello, this is, I'm just using them as an example. Obviously, they're probably one of our biggest, if not our biggest client. Hello, this is, the CEO of General Motors. I want to buy 500,000 plans this year. That's not really how it works. Sort of your big organizations like that, they're what we call our self-funded customers. We administer it for them. They're actually paying the bill. So we can have a benefit and says, everyone should have watches that tell if you're an AFib. and we can call it a benefit, they can say, that's a great benefit, we're not paying for it. And the other way around, we can say, well, something's sort of questionable. They're saying we want to pay for it. And then, we administer it then. It's our, the ones that actually buy insurance, the insurance that you think about, that actually is what our benefits plans actually come up with. So what's the JUMP committee do? They look at the safety and effectiveness. They look at the margin of improvement. They actually take a look at reproducibility and the quality of the evidence. And then they make a really sound clinical judgment. There's no bean counters in the room. There's no economists in the room. There's no actuaries in the room. And at Blue Cross, it's pretty tough to keep an actuary out of the room because they love being there. They're everywhere. As a matter of fact, I'll tell you something. If you ever get in this business, and you just want to delay a discussion. I do it all the time. It's like, just call actuary. Because they can go in, and by the time they slice and dice and they come up all the data 6 months later, and they come up with something that you're like, okay, whatever. So that's something that's we do this independently, and that's what we decide. If a product comes through, if a device comes through, it goes to the JUMP committee. Now the JUMP committee can only deal with commercial because we have all these separate rules for our Medicare Advantage patients that actually come from CMS, and that's a whole different team that works on those policies, because those policies have to be very consistent with what CMS advocates. So after they evaluate it, they determine it. We ensure that the technical requirements are all set. It's really hard. You say to yourself, I can't tell you how many times this happens. We process billions of claims a year. Think about it. If one person, one member gets a CBC, and then a blood draw, and then an EKG. Think of all these claims benefits. Do you ever open up your explanation of benefits and it comes like, in a binder that big, and you're only in the hospital 2 days? So we just process billions of claims every year. But we have to make sure if we approve something that there's a code, that the systems are correct, that the right people will get paid for it, because not everyone gets paid, can get the same benefit for the same person. And it's an incredibly complex web. And then we have to make sure that the self-funded groups are pretty much on board. So we can approve a device, and if the self-funded groups aren't on board, we have to make sure it's programmed so that the beneficiaries in that self-funded group don't get it paid for. So it's actually a complicated web, but you actually can get it through the system that way. So what's an example? So an example of was lymphedema. So a current medical policy says that a bioimpedance device, because someone said, give us an example of getting something through the system. So a bioimpedance device for cancer-related lymphedema is currently investigational. Investigational products are not considered a covered benefit. Makes sense to you? It makes sense to me when I first got there. But all parts of the policy were reviewed, and actually the JUMP committee actually saw a lot of new evidence that came out, showing there's a lot of clinical publications with really great subject matter experts in the provider network that really consider the guidelines from the National Cancer Network. And the JUMP committee determined that actually the bioimpedance device for lymphedema is established. So it was considered investigational, but we brought the key subject matter experts in the room, and they said, well, technically it's labeled investigational, but these are the great things that's happening. And we've approved it. And once we've approved it, it's now, our members have access to it, and it's actually considered a covered benefit. And the last thing I want to talk about is what's called the Blue Venture Fund. And the Blue Venture Fund, it's they're angels. The Blue Venture Fund is all except for one of the Blue Cross plans that are together. It's a totally separate entity, totally independent, totally financially separate, that actually will take good products. If you bring a device to the Blue Venture Fund that you think is really good, that you need growth money for, you need seed money for, you need round 1 or round 2 funding for, the Blue Venture Fund will actually be there to help fund it. And the Blue Venture Fund funds millions and millions of dollars of projects every year. And again, it's independent, it's the not-for-profit blues that get together to see if we can fund better healthcare, if we can fund better ways of taking care of people. And that's what it's all about, especially at the not-for-profits. I'm not here to talk about the health plan, but what I'm here to talk about is the health plan realizes that if we can keep people out of the hospital, if we can take care of better people, we can use technology to our advantage, and actually, at the end of the day, it's going to be a better, healthier population for everyone. So on that note, thank you. And I think next is the panel, or is next? Okay.
Thank you, Jim.